introduce our two presenters today. We have Bryce L., who is currently the manager of ambulatory optimization at the Norman Regional Health System in Norman, Oklahoma. Bryce has 7 years of healthcare experience and has worked in many settings, including telehealth, clinic operations, the operating room, and laboratory. He's passionate about high-quality, convenient healthcare delivery, and over the last 3 years has learned how frontline innovation can improve healthcare delivery for the long term. Bryce holds a bachelor's degree in clinical laboratory science and a master's degree in healthcare administration from Texas Tech. The other presenter is Shelbi Geresi. Did I get that right? Okay. Shelbi is currently the Norman Regional Health System project manager for specialty and ambulatory clinics. She previously held the role of telehealth coordinator for the health system and has a background in clinical patient care, telehealth optimization, and project management. Shelbi has a passion for supporting providers and staff in their efforts to deliver exceptional patient care. A lifetime Oklahoman, she attended Oklahoma City University, where she obtained a Bachelor of Science in Cell and Molecular Biology and holds a Master of Health Administration from the University of Oklahoma. So welcome, Bryce and Shelbi. We appreciate it. So again, building off our Telemedicine Echo program that we wrapped up in July, we continue to keep momentum through our Echo series to build and expand telehealth programs in the tri-state area and beyond. If you're new to the Telemedicine Echo series, previous Echoes are available on the HTRC YouTube channel, and we'll drop the link in the chat shortly. So Shelbi, Bryce, please take it away.
Tim, thank you for the introduction there, and I won't go too much on about this, but being a Texas Tech grad, we miss our Missouri Tigers, and if you guys ever want to come back to the Big 12, just feel free, and I'll do what I can to help out. I could go on and on about that, but I won't. I'll go ahead and dive into our content here, and Shelbi is going to share the slides, and today what we'll be talking about is improving quality and patient engagement through remote patient monitoring here at the Norman Regional Health System. So just a little bit more background on the Norman Regional Health System. We're a 2-hospital system based in Norman, Oklahoma, just south of OKC by about a half hour. We've got, like I said, 2 hospitals. I think between the two, about 400 inpatient beds. We offer care, everything from neurosurgery to primary care and beyond. We've got a clinic network, about 40 different clinics spanning from, like I said, primary care to neurosurgery. And of course, when the pandemic surged in 2020, everybody started doing a number of different things via telemedicine that they weren't doing before. And that's where I stepped in. I kind of took the department of telehealth over in 2020, and the last 2 or 3 years have learned just so much about innovation in the front lines and how can we sustain that innovation. And I think that's really where we'll focus today. So jumping in, we'll be talking about our remote patient monitoring program today. And the goal of the Norman Regional Remote Patient Monitoring Program is to improve post-operative care and patient outcomes through the innovative use of technology. And that's our goal today. Our goal in the past, we started remote patient monitoring with COVID-19 patients, and our goal then was just to help patients feel more connected to a provider and kind of really to help reduce that anxiety that those COVID-19 patients, especially early on during the pandemic, had. That anxiety, for the most part, was just related to not knowing what was going on internally once they tested positive for COVID-19. And so there was a need to help make these patients feel that they were well connected to a healthcare provider, and remote patient monitoring was a great way to do that. And we took some lessons learned and applied it to other populations and other team members, other stakeholders within the system, and here we are today. So Shelbi, if you could go to the next slide. Just talking about the background a little bit more. You guys all know remote patient monitoring is a collection of health data from the point of care. This could include vital signs, weight, and blood pressure. It could also include things like surveys and images of surgical sites. The data is transmitted from where the patient's at to healthcare professionals in hospitals, primary care settings, skilled nursing facilities, and anywhere that a nurse can have a desk and check in on a portal, essentially. Like I mentioned earlier, in 2020, Norman Regional received grant funding through the COVID-19 telehealth program CARES Act, funded by the FCC. And that enabled us to kick off our remote patient monitoring program. Remote patient monitoring, sorry about that. Remote patient monitoring was used at the height of the first surge of the pandemic here in Oklahoma in November of 2020 to, like I said earlier, ensure that our COVID-19 positive patients felt more connected to their healthcare provider, and if needed, could be steered to the proper level of care. Back in those early days, there wasn't really much that emergency department providers could do for patients that tested positive for COVID-19 if they had, mild symptoms and weren't in need of oxygen. And so we originally thought of this idea to again ensure that these patients that were highly anxious weren't going to the emergency department, and that our emergency department resources and emergency department providers could deliver the highly acute care in a timely manner that they needed to those patients that needed it most. So that's where remote patient monitoring started with Norman Regional. And Shelbi, we'll go to the next slide. In middle of 2021, we kind of shifted our remote patient monitoring resources away from COVID-19. I think we learned that if our care coordinators could connect these patients to our infusion center, there maybe were 2 or 3 days where remote patient monitoring was advantageous for COVID-19 patients, but after they got infusion and their symptoms started improving, they really didn't need remote patient monitoring outside the first 72 hours. And due to limited resources, we wanted to start evaluating where could these remote patient monitoring hardware and software start being used more effectively. And we worked with our transitions of care and care coordination team to identify the comprehensive care for joint replacement program here at Norman Regional as a great population to focus on, especially for those Medicare patients, obviously Medicare patients in the CJR model, just because the goal there is to, reduce high cost setting of care utilization and steer those patients to a proper setting of care and help them, understand the level of access that they have to our health system, whether that be, the orthopedic surgeon who's performing the surgery, or, connecting them to an urgent care within the health system, or connecting them back to their primary care provider. So that was kind of the goal of our CJR program or of our remote patient monitoring program within CJR. And just a little tidbit there, we began participating in CJR in 2016. Shelbi, next slide. I think I'll hand it off to you.
Okay, thanks, Bryce. So our remote patient monitoring process had a couple of different facets to it. That CJR population, they were typically scheduled for their elective knee or hip replacements at least a week or two in advance, sometimes even months before. So we utilized the nurse navigator for that population and just worked off of her process that she already used and found how we could work in remote patient monitoring to help her, but also help that patient population. So the way it started, that nurse navigator would send out an instruction guide to the patient when she mailed out all of their other pre-op instructions, and she would communicate with the patient in the days leading up to the procedure, making sure they've done all their pre-op testing and helping to determine if they were prepared for surgery and going to have the most successful outcomes that they can. So in that time, the patient would ideally download the mobile app to their device, and we partner with Health Recovery Solutions for our remote patient monitoring program. They would download the app, and in their instruction guide would tell them, wait until you get discharged from the hospital, and then we'll help you set up your app and show you how to use it. We did find that helping patients, when they're still in the hospital right after their surgery, they are still kind of wearing off of anesthesia, and they just have a lot of things going on as far as a lot of education, a lot of people coming to talk to them to, help prepare them for recovering at home. So we found that calling the patients once they got home and were more comfortable, more in a routine, was really helpful in them really being engaged with the program. So the nurse navigator would enroll the patient into their Clinician Connect portal, where they could monitor the patient submissions. And then once the patient downloaded the Patient Connect mobile app, we were able to help them get logged in with just some activation codes. They didn't have to remember a username or password, which this population really appreciated. And they would receive medication reminders, just reminding them to take their anticoagulant at the same time every day, preventing any kind of blood clots. They would get a short 4-question survey every morning, just asking them what their pain level was like, if they had any openings of their incision or any drainage, just looking at preventing any kind of infection that would lead to an emergency room visit or readmission. And they also have the option to submit images of surgical sites through the wound imaging feature. And I've included a couple of screenshots on this slide as well, just to show you what the app looks like right here, just very easy for patients to navigate. And their reminders they would get every day just kind of popped up on their lock screen like so. Additionally, patients have the option to go into the menu of their app, which they can access through these 3 lines here, and they can actually directly get in contact with their nurse navigator. So, once they get home from the hospital, they may have that nurse's business card, but a lot of those things get lost, paperwork gets misplaced. So it was really great to have a one-stop shop for patients to click a button and be able to call, voice, video call, or message their nurse and ask their questions directly through that. So that really gave them enhanced access to their care. They also had the option to access educational materials. So we had videos on how to properly ice and elevate after surgery for knee replacement patients, and also a little video telling them about how to manage their pain after surgery, because those were a lot of questions that our nurse navigators were used to answering and explaining. So just being able to show them, hey, if you have any questions about this, we've uploaded this, and it'll show you exactly how to do this to recover the best that you can. And like I said, we gave out instruction guides for patients to help use the app, including lots of screenshots, and this light keeps turning off. Lots of screenshots to help them navigate the app and help them navigate how to get a hold of their nurse navigator, as well as an informational brochure that included some of our results in there, just to show them how this can help them as they are recovering from their surgery. So with that, we did see significant results, both in quality and operational impact for our health system. We saw a reduction in ED visits and readmissions within 30 days of discharge. And this data was over the time of from August 1st, 2021 through the end of April 2022. We saw a 73% decrease in emergency department visits and a 78% decrease in readmissions in this population when compared to our baseline data. Additionally, looking at the operational impact, we did see a significant cost savings by reducing ED recidivism and readmissions in this population. And because we do participate with the CJR model with CMS, we did see that positive reconciliation for meeting those quality standards with Medicare. Additionally, in this year, our team, as well as the Transitions of Care team, were recognized by our health system by winning the Innovation of the Year award. And this is given to the group that uses technology or an innovative process to improve patient satisfaction, or process improvement, improved efficiency. And we were able to really touch on all of those pieces. In addition to that, our team presented at last month's telehealth summit put on by Teledyne Health here in Oklahoma City. And we had a great turnout there, and happy to be recognized for that. And so we saw that the benefits for patients and the improved quality by reducing ED visits and readmissions, but we also saw a sense of increased patient safety because patients could instantly get a hold of their nurse navigator, ask their questions, and be connected with somebody who could get them to the proper level of care if they did need to get in to see their surgeon. In addition to that, we saw enhanced patient satisfaction and engagement. And the way we measured this was through our remote patient monitoring app. We were able to send out a 5-question survey, just asking patients about their experience with the remote patient monitoring program. So that went out to patients, I think, after about 2 weeks of being enrolled in the program. And we found that 95% of patients would recommend the program. 82% of patients surveyed said they were more engaged with their care because of their participation in the program. And that is such a big one to us because we know more engaged patients are going to be more educated and ultimately have better results when they are more engaged in their care. And 92% of patients said they would participate in the program again. I can confirm we did have a handful of patients that had their right knee replaced one time, and then a few months later came back and had the left one replaced, and were very excited to download their app again and get reactivated so they could use the remote patient monitoring app again. And in addition to benefits for our patients, we saw a few benefits for our clinicians that are working with these patients and our health system. I did already touch on the return on investment and cost savings associated with the program. But we also saw a significant improvement in the process that our nurse navigators were using, and it also improved the efficiency of their process as well. So in the beginning, before we initiated remote patient monitoring with this population, the nurse navigator pretty much followed the exact same process that she follows now. But once that patient was discharged, she would call the patient at different intervals and just check on them, ask them the same questions that we asked in our daily surveys through the app. And she would spend probably about 10 to 20 minutes with each patient, chatting with them and asking those questions. But we also found that, if she called every 3 days, patient may be fine on the first day she calls, but by the time she calls after 3 days, they could have already had an issue and gone to the emergency room for that. And that was something, it was kind of hard to triage patients and know when they needed additional phone calls from her and additional education on where they should be going and what they should be doing to resolve any issues after surgery. So our nurse navigator for the CJR program, she really loved the ability she had with the remote patient monitoring program to triage her patients through that portal and see, which patients are at more of a high risk than others and which ones do I need to call first. And it also helped her because a lot of patients, when they go through a surgery like this, I always say you'll never feel more like a celebrity until you have a knee replacement, because you have so many people calling you and making sure you have everything you need. So just being able to reduce maybe the number of phone calls for a patient that is a little bit overwhelmed is really helpful for them. Rochelle also loved that the patient's app allowed her to provide a little more education without having to repeat herself a few times. So she could add things in the medication reminders, letting them know, hey, make sure you take this the same time every single day, because it's really important to your recovery. We want to make sure, you have the same amount of that medication in your system every 12 hours. So she loved having those additional pieces to be able to educate her patients that way. And I will hand it back over to Bryce to talk a little bit about what is next for the RPM program.
Yeah, so with lessons learned not only from our COVID-19 remote patient monitoring program and CJR remote patient monitoring program, we wanted to move on to a more a population with a greater opportunity to improve outcomes, and we targeted our COPD population next. Those are Medicare patients with COPD, and started that program in April. Again, the goal was to reduce the high cost setting of care utilization for that patient population. And, of course, we've learned that this patient population, they're just not as open to the idea of remote patient monitoring as the CJR population for a number of different reasons. And some of those reasons are related to social determinants of health. But I think just generally, we find that these patients are a bit more stubborn than our CJR patients are. But like I said, a great opportunity to improve outcomes. And it's been good to see our results so far, and volume steadily ticking up. And then in May, we also expanded to a CHF population, and we're working with our primary care leaders to begin enrolling patients in the clinic, maybe before they're even admitted to the hospital, just once they have that initial diagnosis of CHF or COPD, so we can reduce those episode of care costs. So we're excited to see where this program goes. And the name of the game is still the same, just reducing high cost setting of care utilization, helping patients feel more engaged in their care plan, and making sure that they feel connected to a healthcare provider. I think that's all we've got, right, Shelbi?
Yeah.
Perfect.
Great. Well, thank you guys both so much. So it was a very good, informative presentation about the remote patient monitoring system there at Norman Regional for the joint replacement group. Were there any clarifying questions from any of the participants today? And Shelbi and Bryce did email me separately and said they wanted all the hardest questions today. So don't get their money's worth. So I said, bring it on, I think is what they said. So
I have a quick question. This is Shonda from SSM Help. Is the RPM device, is that incorporated with like Tidal Care or any other like at-home monitoring for the patient to be connected back to the hospital?
No, the devices that we do distribute are connected only to the app, or at times we have the opportunity to give patients a tablet for this program. So the devices only connect via Bluetooth to the tablet or the app that the patient downloads on the phone. We do have an engagement with Tidal Care, and we use it for separate telehealth workflows. I think early on we found that training patients on how to use an app, how to use a pulse oximeter, a scale, blood pressure cuff was hard enough. And then training them on how to use a Tidal Care device was just a little overwhelming. And there was a couple other operational constraints associated with Tidal Care as well. So, yep.
yeah, great question, Shonda. Any other questions for Shelbi or Bryce? How about, yeah, Rachel, how about from our hub team?
I was trying to be patient and wait and see if other people. So, what a great project! Congratulations, you guys. I have several questions, but I'm just going to ask one related to the one that LaShonda just had. Within that software, that app software, did you have to buy different customizations for the different diagnoses for the different projects? Did that question make sense?
Yes, and now there was a little technical glitch, so I hope I answer your question. I think what I heard you say is, is the app that we have customizable to the diagnosis that the patient has. And so, when we partnered with Health Recovery Solutions, we were looking, at the time, Health Recovery Solutions was best in class, KLASS for those familiar with that. They're really great on giving third-party reviews on technology and just different tools that are available to us in healthcare. But they're best in class, and one of the reasons they're best in class was for their flexibility. So we can customize survey questions, we can customize the medications, the dosages, the times that all of these things are set to ping our patients and notify our patients that it's time to engage with the app. It's very customizable, and it's customizable down to the patient themselves. You know, you can create a custom plan for a patient, or you can create a custom plan for a patient population. So really flexible. And they can also, the one thing they can't do is white label the app to reflect your health systems app. That was the one bad thing about health recovery solutions. But other than that, yeah, really user friendly and customizable.
And Rachel, there was no additional cost to customize to those conditions either. That just kind of came with it. If they could customize it, they could do it.
Great, thank you guys. Jennifer Allen, I believe, had a question.
Yeah, this is Jenny Allen with MD Live and Gold Care. I was curious if these people have to have Wi-Fi too, or is this just using communication towers for cellular? Knowing not many older people have Wi-Fi.
So the tablets we have are connected to cellular data. The app itself, you can use cellular or Wi-Fi.
Okay. Molly Brown.
Thank you. What a great presentation. I too have a lot of questions, but I'm going to keep them close, actually just mainly around evaluation. And when you talked about landing on this CJR model, you said you had done, I think, an internal review on how to apply remote patient monitoring to services within. What are some like big picture things that you evaluated to land on certain diagnoses or programs that you wanted to implement this with?
Yeah, I think first we took advantage of the fact that we already had value-based contracts in place with Medicare around CJR. We also have them in place with COPD, CHF. So we really, I think we engage in 22 total value-based contracts. So there's a number of different metrics we can look at and key performance indicators we can look at a high level to assess, you know, where we want to, or what population we want to target next. But that's the gatekeeper is this a value-based contract or a population that participates in a value-based contract, I guess you could say. The second thing we look at is, you know, emergency department recidivism and then readmission rate within 30, 60, and 90 days. And then I think third, we kind of looked at social determinants of health and, you know, which populations do we think would be most open to participating in this type of program. And CJR, you know, with these being elective procedures, with the CJR program in itself being part of a value-based contract, and you know, with us working to reduce that high cost setting of care, it was kind of a no-brainer to start there. And luckily, you know, we have a culture here at Norman Regional, which is to, you know, just constantly try and improve patient outcomes and patient experience and operational impacts. And yeah, that kind of opened the door for us to get into those populations with our remote patient monitoring program.
Can I just say something and ask a question, Molly? Is that okay? Oh, can you guys hear me?
Yes, yeah, you're good.
Okay.
Yes, we can.
Maybe I should turn my video off. So first of all, congratulations. What a great project. And, you know, for those of us who've been in telehealth since the dawn of time, this is so much fun because we've always said, once you move in healthcare from paying for volume to paying for value, then all of a sudden, all forms of telehealth make so much sense. And so that's just a wonderful program you guys are doing. One of the questions I have, and you know, it's going to be so important to really do the return on investment for these things, as you guys know. And I love seeing that 73% reduction in ED visits and hospitalizations and things like that. But could you give us a little sense of what the denominator is there?
Well, our finance team and our clinic care coordination team, you know, we have a really robust clinic care coordination program. I keep saying clinic care coordination. It's just kind of case management and care coordination in general. We've got transitions of care coordinators, acute care coordinators, and then clinic care coordinators. And so our finance team years ago worked with that group to assess, what's the real return on investment with value-based contracts and these types of programs. And looking at that shift from volume to value, that's a tough shift to make for a number of different CFOs in healthcare. And as I understand it, years ago, our finance team got together with our clinic care coordination team and said, here's the real value. If we can have this patient who's participating in a value-based program, and they, have a reduced episode of care cost, here's the additional revenue, the incremental revenue, if you will, derived from that patient not using the emergency department or not readmitting within that 90-day period. And so, the denominator, I think, is just monitoring those patients and their 90-day episode of care cost, and looking at how often they utilize the emergency department and are readmitted. And Shelbi, you may be able to speak to that a little bit more, but I think the answer is, just ED visits and readmission rates.
Agreed.
Great, thank you. Do you have, I had a question, if no one else has a question, I'm not seeing any hands up, but do you have like an average age of the joint replacement patient? And were there any kind of, I know Shonda kind of talked about connectivity, but were there any other implementation issues on a patient side, from, I don't know if they had devices at home or just downloading the app and being able to use them, etc.
I would say probably we didn't actually calculate average patient age, but these were Medicare patients. So really probably most of them fall in their 70s for the most part. We did have a few issues with patient engagement at the beginning, just being able to present it to patients where, they want to participate. We found a couple of, got some hesitancy on, downloading another app. I'm the same way. If I have to download an app, I've got so many, do I really need to do this? And also, I have so many passwords, how am I going to remember this? So it was really great to present it to them by saying, yes, we'll download an app, but you actually don't have to create an account. We will just give you these codes to log you in. And then once you're logged in, you never have to log in again until we go in and deactivate you. So that was really helpful as well, just showing them that this isn't a lot of work on your end, very simple to do. And then also just telling patients that, we've got this really broken down to just a few activities for you, trying to help them understand that it wouldn't be super overwhelming. Because like I said, after a surgery like that, you get so many activities to do and phone calls and home health is coming. So we did see a little bit of that where patients were overwhelmed that they didn't want to participate in another activity.
Yeah, completely understandable. Thank you.
This is Rachel from Missouri. I've got another question. Just as you move forward into your new projects with COPD and CHF, I was wondering, are you also limiting those to Medicare participants, or is that going to be a more broad population of payers?
We do have a couple value-based contracts outside of the Medicare population. So to answer your I think the simple answer is yes. I think the end goal is to really focus on those dual eligible patients as well, the Medicare and Medicaid covered population. But so yes, we're looking at other payers outside of Medicare.
That's great, thank you. And then one follow-up to that is, were video visits any part of that? Does that app allow for video visits, or was that any piece of the project?
The app does allow for video visits. To my knowledge, we've never done a video visit through the remote patient monitoring program. We've got a separate telehealth solution for our video visits out in the clinics, but The app also allows for telephone encounters as well as texting, and so our patients love using the texting feature within the app. I've never heard a bad review from our nurses that are using the program either about texting patients. And I think that there have been a few phone calls exchanged, but never a video visit to my knowledge. The video visit software within the app is kind of based on, or I guess the backbone of the video visit software is actually Zoom. And so it's not as seamless as you'd like to think. I think that's been a barrier.
Yeah, thank you.
Great. Shonda, I think you had another question.
I was just gonna ask about, are these series type patients, or are they billed weekly or monthly?
So for our CJR program, we don't bill for the service. We don't have a provider yet who's really overseeing the service. Again, all of this kind of goes through our clinic care coordinators and our nursing teams. That's a next step for us, is kind of getting it to the point where it's overseen by a provider, and we're working with the orthopedic team to make that happen, but haven't made that jump yet. And then also, I think just per the description of the service, we really don't meet, our CJR program really doesn't meet the criteria for any codes to be billed. We're still kind of investigating that, but our initial interpretation is that we really aren't providing a service that meets criteria to be billed with our CJR program. For the CHF and COPD program, we're going to be distributing devices out of eventually out of primary care clinics, and that's where we do hope to bill on a monthly recurring basis for these services.
Great. So Bryce, I would assume, even though you're not billing for this, the reduction in ED visits and et cetera, that's really where kind of the cost savings or the revenue generation, so to speak, is actually coming from. So I think that's always important going forward with telehealth, is maybe it doesn't necessarily drive direct revenue off of it, but the cost savings we can do on the back end kind of definitely makes up for that. So fantastic. All right, any other questions from any of the participants or hub team?
I have one more.
Go for it. You said you had a couple before. Just go list them all out. Yeah.
Okay, so this one has to do with when we're talking about patient engagement, and for years it seems like through the electronic health record, organizations want or are pushing patients towards the portal.